Congenital diaphragmatic hernia results from a failure in diaphragmatic development, which creates an opening through which abdominal organs can migrate into the thoracic cavity. This herniation compresses the lungs during fetal development, leading to pulmonary hypoplasia. The reduced lung size limits alveolar number and surface area, and the pulmonary vasculature develops abnormally, increasing pulmonary vascular resistance and predisposing the infant to persistent pulmonary hypertension at birth. CDH is relatively uncommon, occurring in roughly 1 in 2 to 4,000 live births, but its impact is significant due to the frequent coexistence of other anomalies. Up to 50% of infants have associated conditions, most often involving the heart, genitourinary system, or chromosomal abnormalities. The combination of lung compression, abnormal vasculature, and associated anomalies creates a clinical scenario in which immediate attention to airway, ventilation, and hemodynamic support is critical, and early anticipation of pulmonary hypertension guides management strategies from the moment of delivery. The most common form of congenital diaphragmatic hernia is the Bochdalek hernia, located posterolaterally. These defects are usually left-sided and account for over 80% of cases. The left-sided predominance contributes to more severe pulmonary hypoplasia because the left lung is smaller and compressed by herniated abdominal contents. Morgagni hernias are anterior or retrosternal and are much less common. They are often right-sided and may present later in infancy or childhood with milder respiratory compromise. Central diaphragmatic defects are rare and show variable clinical severity depending on size and associated pulmonary hypoplasia. Each type of CDH affects lung development differently, and understanding the location and type of hernia guides both prenatal counseling and postnatal management strategies, including anticipation of ventilation challenges and potential need for surgical repair. Congenital diaphragmatic hernia arises from incomplete closure of the pleuroperitoneal folds between 4 and 10 weeks of gestation. The posterolateral, or Bochdalek, defect represents the vast majority of cases, while anterior, or Morgagni, defects are rare, and complete agenesis is an extreme form. The failure of diaphragmatic development allows abdominal viscera to herniate into the chest, compressing the ipsilateral lung and often affecting the contralateral lung as well. This compression disrupts normal alveolar and vascular growth, and the pulmonary arteries undergo remodeling that increases pulmonary vascular resistance, setting the stage for postnatal persistent pulmonary hypertension. The severity of hypoplasia and vascular changes correlates with the timing and size of the defect, making early prenatal detection and careful monitoring critical for planning postnatal support and interventions. In congenital diaphragmatic hernia, herniation of abdominal organs into the thoracic cavity compresses the developing lungs, which disrupts the normal branching of both airways and pulmonary arteries. This compression limits alveolar multiplication and reduces the overall surface area available for gas exchange, which directly contributes to postnatal hypoxemia. The restricted space also alters the structural development of pulmonary arteries, causing medial hypertrophy and decreased arborization, which increases pulmonary vascular resistance. High pulmonary vascular resistance before birth sets the stage for persistent pulmonary hypertension of the newborn, PPHN, because the vessels are structurally and functionally abnormal. Surfactant production and function are also impaired, partly due to fewer type 2 alveolar cells and altered alveolar stretching. Surfactant dysfunction further destabilizes alveoli, increasing the work of breathing and susceptibility to atelectasis at birth. Additionally, when the defect is left-sided, the left ventricle often develops with reduced mass and volume because of decreased pulmonary venous return and altered intracardiac flow patterns. This ventricular hypoplasia compounds the risk of low cardiac output after birth. These intertwined effects, mechanical compression, disrupted alveolar and vascular growth, surfactant deficiency, and altered cardiac development, explain why CDH infants frequently present with severe respiratory failure and PPHN immediately after delivery. Understanding this cascade clarifies why gentle ventilation strategies, early hemodynamic monitoring, and anticipatory management of pulmonary hypertension are essential from the first moments of life. The primary complications in congenital diaphragmatic hernia arise from the interplay of pulmonary hypoplasia, pulmonary hypertension, and ventricular dysfunction. Pulmonary hypoplasia manifests as reduced lung size and weight, with fewer and smaller alveoli, thickened alveolar membranes, and abnormal interstitial tissue. These structural changes impair gas exchange, limit oxygen uptake, and increase the risk of ventilation-perfusion mismatch. Pulmonary hypertension develops due to abnormal vascular remodeling, including medial hypertrophy and adventitial thickening, coupled with reduced vascular arborization. These changes elevate pulmonary vascular resistance and impair vasoreactivity, creating the substrate for persistent pulmonary hypertension after birth. The resulting high pulmonary pressures increase right ventricular workload and contribute to shunting through fetal channels, further worsening oxygenation. Ventricular dysfunction, particularly of the left ventricle, arises from structural hypoplasia and altered geometry caused by chronic right-sided pressure overload. Septal displacement further compromises left ventricular preload and diastolic filling, which can reduce systemic output and exacerbate hypoxemia. The overlap of these three processes explains why CDH infants are at high risk for immediate respiratory failure and cardiovascular compromise, and why management must address oxygenation, pulmonary vascular resistance, and cardiac performance simultaneously. Congenital diaphragmatic hernia occurs in approximately 1 in 2,500 to 4,000 live births. The majority of cases are left-sided, accounting for 80 to 85%, with right-sided defects representing 10 to 15%, and bilateral defects being rare, under 2%. There is a slight male predominance with a ratio of roughly 1.4 to 1. Genetic contributions are significant. Chromosomal anomalies, including trisomies 13, 18, and 21, as well as monosomy X, are commonly associated. Syndromic presentations such as Fryns, Pallister-Killian, Charge, and Beckwith-Wiedemann are also observed. Up to half of infants with CDH have additional anomalies, with congenital heart disease being the most frequent. These epidemiologic and genetic patterns help guide prenatal risk assessment and counseling. Recognizing associated anomalies is critical because they influence both the severity of pulmonary hypoplasia and postnatal management strategies. For instance, cardiac defects may exacerbate pulmonary hypertension or complicate ventilatory support, necessitating tailored hemodynamic monitoring and multidisciplinary planning immediately after birth. Prenatal diagnosis of congenital diaphragmatic hernia is primarily achieved through ultrasound between 18 and 22 weeks gestation. Sonographic evaluation identifies abdominal organs such as stomach, bowel, and occasionally liver within the thoracic cavity, along with mediastinal shift and polyhydramnios, which are indicators of significant lung compression. Fetal MRI provides more detailed assessment, quantifying lung volumes, determining liver position, and clarifying the degree of mediastinal shift. MRI also helps differentiate CDH from other thoracic masses, such as congenital pulmonary airway malformations or bronchopulmonary sequestration. Early and accurate prenatal detection allows for risk stratification, anticipatory counseling regarding potential postnatal respiratory compromise, and planning for delivery in a tertiary center capable of advanced respiratory support. The ability to predict the severity of pulmonary hypoplasia and the likelihood of persistent pulmonary hypertension guides decisions on the timing of delivery, the need for immediate intubation, and potential consideration of fetal interventions in select high-risk cases. Several prenatal markers help predict postnatal outcomes in congenital diaphragmatic hernia. The lung-to-head ratio, LHR, compares the cross-sectional area of the contralateral lung to head circumference, and observed to expected, O/E, LHR below 25% indicates a high risk for severe pulmonary hypoplasia and poor survival, while values above 45% correlate with improved outcomes. Liver herniation into the thoracic cavity is another strong adverse factor, as it further restricts lung growth and is associated with higher rates of persistent pulmonary hypertension and need for advanced respiratory support. Some centers also use the congenital volume ratio, CVR, which assesses the relative size of the herniated mass to refine prognostication. The presence of fetal hydrops is universally recognized as a poor prognostic indicator, reflecting both severe lung compression and cardiac compromise. These markers inform prenatal counseling, guide decisions regarding fetal therapy, and prepare the neonatal team for the anticipated severity of respiratory and cardiovascular compromise at birth. By quantifying lung size and herniation extent, clinicians can anticipate ventilatory challenges, the likelihood of pulmonary hypertension, and the potential need for interventions such as ECMO or delayed surgical repair. For severe congenital diaphragmatic hernia, fetal interventions may be considered to promote lung growth before birth. Fetal endoscopic tracheal occlusion, FETO, involves placing a small balloon in the fetal trachea to trap lung fluid, which increases intrapulmonary pressure and stimulates lung expansion. This intervention is typically reserved for cases with an observed to expected LHR below 25%, where the risk of severe pulmonary hypoplasia is highest. The procedure carries significant risks, including premature rupture of membranes and preterm labor, and requires careful maternal-fetal monitoring. Prenatal counseling is essential to set realistic expectations regarding survival, postnatal morbidity, and potential interventions after birth. Multidisciplinary planning involves obstetrics, neonatology, pediatric surgery, and often cardiology and anesthesiology, ensuring that delivery occurs in a tertiary center capable of providing immediate advanced respiratory support, addressing persistent pulmonary hypertension, and coordinating surgical repair when the infant is stabilized. Counseling also emphasizes the uncertainty inherent in prognosis, particularly regarding the degree of pulmonary hypoplasia and the need for interventions such as ECMO or prolonged mechanical ventilation. Infants with congenital diaphragmatic hernia typically present within minutes to hours after birth with severe respiratory distress. The mechanical compression of the lungs results in cyanosis, tachypnea, grunting, and retractions. On physical examination, a scaphoid abdomen indicates loss of abdominal contents into the thoracic cavity, while the chest may appear barrel-shaped with mediastinal shift toward the contralateral side. Heart sounds are often displaced, and breath sounds are diminished or absent on the affected side. Laterality influences presentation. Left-sided defects are most common and usually identified prenatally, whereas right-sided hernias may be subtle and sometimes missed until postnatal respiratory compromise occurs. The combination of reduced lung volume, pulmonary hypoplasia, and pulmonary hypertension explains why these infants often require immediate intubation and careful ventilatory management. Recognizing these hallmark signs allows the clinical team to prioritize airway stabilization, preductal monitoring, and rapid initiation of gentle ventilation strategies while preparing for possible ECMO or surgical intervention. Chest radiography in congenital diaphragmatic hernia provides definitive postnatal confirmation of herniated abdominal contents. Loops of bowel, stomach, or solid viscera are visualized within the thoracic cavity, often accompanied by a gasless abdomen. Mediastinal structures, including the heart, are shifted to the contralateral side, and the affected lung appears hypoplastic with poor aeration. The compressed lung is at high risk for atelectasis and pneumothorax, especially during positive pressure ventilation. Prenatal imaging, such as ultrasound or MRI, may have predicted the severity of pulmonary hypoplasia, but the chest X-ray immediately after birth guides acute management decisions. It informs the clinician about lung volume, potential for overdistension, and the need for careful adjustment of ventilatory pressures. Recognizing the anatomical displacement and degree of lung compromise allows early implementation of lung protective strategies and alerts the team to anticipate persistent pulmonary hypertension and hemodynamic instability. Immediate postnatal stabilization focuses on protecting the hypoplastic lungs from further injury. Infants with CDH should be intubated promptly. Bag mask ventilation is avoided because it can insufflate the stomach, worsen diaphragmatic compression, and further reduce effective lung volume. A gastric decompression tube, such as a Replogal, is placed early to evacuate air and fluid from the gastrointestinal tract. Oxygen therapy is initiated, typically starting with an oxygen concentration around 30 to 50%, then titrated to achieve target productal saturations. Manual ventilation via a T-piece resuscitator is preferred over self-inflating bags to allow precise control of pressures and volumes. Continuous productal monitoring is essential to guide oxygenation, detect right-to-left shunting due to pulmonary hypertension, and avoid hyperoxia or excessive airway pressures. These interventions reduce the risk of barotrauma, overdistension, and hemodynamic compromise, providing a controlled transition for infants with severely hypoplastic lungs and abnormal pulmonary vasculature. Ventilatory management in congenital diaphragmatic hernia aims to optimize oxygenation and CO2 clearance while minimizing lung injury. The hypoplastic lungs have reduced alveolar number, abnormal architecture, and dysplastic vasculature, making them highly susceptible to volutrauma and barotrauma. Gentle ventilation strategies are essential. Peak inspiratory pressures should generally be kept below 25 centimeters of water, and permissive hypercapnia with PaCO2 between 50 and 70 millimeters of mercury is tolerated to avoid overdistension. Targeting productal oxygen saturations of 85 to 95% balances the need for adequate tissue oxygenation with the risk of oxygen toxicity. Achieving adequate functional residual capacity without overinflating the fragile lungs reduces pulmonary vascular resistance, helping to limit the severity of persistent pulmonary hypertension. Sedation and minimizing stimulation are adjunctive measures, preventing acute rises in pulmonary vascular tone that could compromise right ventricular function. These principles guide both conventional and high-frequency ventilation strategies and inform adjustments during delivery room stabilization and subsequent NICU management. Conventional mechanical ventilation in congenital diaphragmatic hernia is designed to provide consistent breaths while minimizing lung injury. Pressure-controlled or volume-targeted modes are commonly used, with rates typically set between 40 and 60 breaths per minute. PEEP is maintained around 3 to 5 centimeters of water, sometimes reduced slightly if overinflation is observed. Target tidal volumes are approximately 4 milliliters per kilogram, and peak inspiratory pressures are kept below 25 centimeters of water. Weaning is performed gradually, first decreasing tidal volume or inspiratory pressure before adjusting the rate, maintaining adequate oxygenation and ventilation while preventing alveolar collapse. If conventional mechanical ventilation cannot achieve sufficient gas exchange without risking overdistension or barotrauma, escalation to high-frequency ventilation or consideration of extracorporeal membrane oxygenation may be necessary. This approach stabilizes oxygenation, reduces pulmonary vascular resistance, and supports cardiac output while protecting the already hypoplastic lungs from secondary injury. High-frequency oscillatory ventilation is used in congenital diaphragmatic hernia for infants with severe respiratory compromise or when conventional ventilation fails. This strategy delivers very small tidal volumes at rapid frequencies, allowing gas exchange while maintaining a relatively constant mean airway pressure. The mean airway pressure is typically set between 11 and 14 centimeters of water, amplitude between 24 and 28 centimeters of water, and frequency between 8 and 15 Hertz. HFOV minimizes volutrauma and barotrauma by avoiding large fluctuations in alveolar volume, which is particularly important in hypoplastic lungs with limited compliance. Volume-targeted HFOV, where available, may further improve survival by maintaining adequate ventilation at lower mean airway pressures. Careful monitoring of oxygenation and carbon dioxide removal is essential, and sedation or paralysis may be used to optimize synchrony and reduce the work of breathing. HFOV serves as both a primary ventilation strategy in severe cases and a rescue modality when conventional mechanical ventilation cannot safely maintain gas exchange. High-frequency jet ventilation is an alternative or rescue strategy for infants with congenital diaphragmatic hernia who have severe respiratory failure. This mode delivers rapid, small bursts of gas directly into the airway at rates of 300 to 420 per minute, with inspiratory times around 20 milliseconds. Mean airway pressure is typically set between 10 and 11 centimeters of water, and positive end expiratory pressure between 6 and 7 centimeters of water. The advantage of HFJV lies in its ability to effectively clear carbon dioxide at lower mean airway pressures, reducing the risk of overdistension and hemodynamic compromise in hypoplastic lungs. By maintaining a relatively stable alveolar volume, HFJV decreases volutrauma and limits fluctuations in pulmonary vascular resistance, which helps mitigate persistent pulmonary hypertension. Settings are individualized based on the severity of lung hypoplasia, oxygenation, and carbon dioxide retention, and careful monitoring is required to optimize gas exchange without causing secondary lung injury. In congenital diaphragmatic hernia, optimizing ventilation requires balancing lung inflation to maximize functional residual capacity while avoiding overdistension. Both underinflation and excessive inflation increase pulmonary vascular resistance, which can exacerbate persistent pulmonary hypertension and compromise right ventricular function. Maintaining appropriate mean airway pressure is essential to recruit alveoli without stretching the fragile hypoplastic lung. Sedation and minimizing stimulation are critical adjuncts because stress or agitation can trigger acute rises in pulmonary vascular tone, worsening right-to-left shunting and hypoxemia. The goal is to maintain a stable alveolar volume, improve oxygenation, and reduce pulmonary vascular resistance while supporting cardiac output. These principles guide adjustments in both conventional and high-frequency ventilation modes, ensuring that ventilatory support does not worsen pulmonary hypertension or cause secondary lung injury. Hemodynamic management in congenital diaphragmatic hernia focuses on maintaining adequate systemic perfusion while minimizing stress on the hypoplastic lungs and right ventricle. Blood pressure is typically maintained in the high normal range, around 45 to 55 millimeters of mercury mean arterial pressure, to ensure adequate end-organ perfusion and support pulmonary blood flow. Vasopressors and inotropes are used selectively. Dopamine or epinephrine are first-line agents, while milrinone may be considered in cases of right ventricular dysfunction or low cardiac output. Acidosis, hypocalcemia, and hypoglycemia should be corrected promptly, as each can exacerbate myocardial depression and pulmonary vasoconstriction. Red blood cell transfusion may be indicated if hemoglobin falls below 15 grams per deciliter to optimize oxygen delivery. Effective hemodynamic management reduces the impact of elevated pulmonary vascular resistance, improves tissue oxygenation, and supports the transition to postnatal life while ventilatory strategies are optimized. Pulmonary hypertension is present in nearly all infants with severe congenital diaphragmatic hernia due to abnormal pulmonary vascular development and hypoplastic lungs. Management focuses on reducing pulmonary vascular resistance and supporting right ventricular function. Inhaled nitric oxide may provide selective pulmonary vasodilation, though its effectiveness is variable in CDH because the structural vascular abnormalities limit responsiveness. Pharmacologic therapies such as sildenafil, prostacyclin analogs, or bosentan are considered for refractory pulmonary hypertension, and prostaglandin E1 can be used to unload the right ventricle in severe cases. When medical management fails and hypoxemia or hypercapnia is persistent, extracorporeal membrane oxygenation provides temporary cardiopulmonary support, allowing time for the pulmonary vasculature to adapt and for stabilization prior to surgical repair. Early recognition and targeted therapy for pulmonary hypertension are critical because elevated pulmonary pressures significantly influence oxygenation, right ventricular performance, and overall survival. In congenital diaphragmatic hernia, surgical repair is delayed until the infant is hemodynamically stable, with fraction of inspired oxygen less than 0.50 and an oxygenation index below 9. During the operative period, gentle ventilation is maintained, often using high-frequency ventilation if the infant required it preoperatively. Postoperatively, weaning from mechanical ventilation is guided by blood gas measurements and imaging to ensure adequate lung expansion without overdistension. Extubation typically occurs between 7 and 30 days after repair, though many infants require ongoing non-invasive support due to persistent pulmonary hypoplasia or pulmonary hypertension. Tracheostomy may be considered for those with prolonged ventilatory dependency. The goal throughout the perioperative period is to maintain oxygenation and ventilation while minimizing lung injury and supporting cardiovascular stability, allowing the repaired lungs to recover and adapt to postnatal function. Surgical repair of congenital diaphragmatic hernia is performed after cardiopulmonary stabilization, typically once right ventricular pressures are less than 80% of systemic blood pressure. The procedure involves reducing herniated abdominal contents into the abdominal cavity and closing the diaphragmatic defect. Small defects are often closed primarily, while larger defects may require a patch. The surgical approach can be open via laparotomy or thoracotomy or thoracoscopic in selected stable cases. Timing and technique are chosen to minimize physiologic stress, as early or emergent repair before stabilization can worsen pulmonary hypertension, compromise ventilation, and increase the risk of hemodynamic instability. Post-reduction, careful attention is required to monitor lung expansion, ventilation, and pulmonary vascular pressures, as even after repair, hypoplastic lungs and abnormal pulmonary vasculature continue to pose risks for persistent pulmonary hypertension and respiratory compromise. Extracorporeal membrane oxygenation is a last-line intervention for infants with congenital diaphragmatic hernia who have refractory hypoxemia or hypercapnia, despite optimized ventilation and medical management. ECMO provides temporary cardiopulmonary support, allowing oxygenation and carbon dioxide removal while minimizing ventilator-induced lung injury. Veno-arterial ECMO is the most commonly used mode, providing both respiratory and circulatory support, while venovenous ECMO may be selected in specific centers for isolated respiratory failure. During ECMO, lung rest strategies are employed, using low ventilatory pressures and minimal oxygen supplementation to reduce further trauma to the hypoplastic lungs. The goal is to stabilize oxygenation and pulmonary pressures, allowing the infant to recover sufficiently for delayed surgical repair and to improve survival in cases of severe pulmonary hypoplasia and persistent pulmonary hypertension. Extracorporeal membrane oxygenation is typically initiated in infants with congenital diaphragmatic hernia when oxygenation and ventilation cannot be maintained despite optimized support. Common thresholds include an oxygenation index greater than 25 to 40 for 2 to 4 hours, a ratio of arterial oxygen to inspired oxygen below 80 on maximal settings, or persistent arterial carbon dioxide above 75 to 100 millimeters of mercury with acidosis. Signs of inadequate perfusion, such as hypotension, elevated lactate above 4 millimoles per liter, or low urine output, also prompt consideration. Relative contraindications include prematurity below 32 to 34 weeks, low birth weight under 1.8 kilograms, major congenital anomalies, or severe brain injury. During ECMO, a lung rest strategy is applied with low ventilator rate, peak inspiratory pressures of 20 centimeters of water or less, tidal volumes of 4 to 5 milliliters per kilogram, and fraction of inspired oxygen under 0.40. Positive end expiratory pressure is individualized, usually between 5 and 12 centimeters of water, to maintain alveolar recruitment without overdistension. Risks include bleeding, stroke, infection, and potential neurodevelopmental delays. ECMO provides a bridge for stabilization, allowing time for pulmonary hypertension management and safe timing of surgical repair. Several factors influence outcomes in congenital diaphragmatic hernia. Prenatally, an observed to expected lung-to-head ratio below 25% is associated with severe pulmonary hypoplasia and higher mortality. Liver herniation into the thoracic cavity further restricts lung growth and is linked to poor postnatal oxygenation and persistent pulmonary hypertension. Bilateral diaphragmatic defects, although rare, are nearly universally fatal due to extreme lung underdevelopment. Postnatally, the severity of persistent pulmonary hypertension and responsiveness to therapies such as inhaled nitric oxide or extracorporeal membrane oxygenation are critical determinants of survival. Overall survival in tertiary care centers ranges from 70 to 80%, reflecting advances in prenatal assessment, delivery planning, ventilatory management, and access to rescue therapies. Recognizing these prognostic indicators allows clinicians to anticipate the degree of respiratory and cardiovascular support needed and informs multidisciplinary planning for delivery and postnatal care. Infants who survive congenital diaphragmatic hernia are at risk for a range of long-term complications. Pulmonary sequelae include chronic lung disease, bronchopulmonary dysplasia, and residual pulmonary hypertension. Gastrointestinal issues such as gastroesophageal reflux, feeding difficulties, malrotation, and failure to thrive are common due to both the hernia and surgical interventions. Neurodevelopmental concerns may include motor and cognitive delays, as well as hearing loss, likely reflecting the combined effects of prematurity, hypoxemia, and complex perioperative care. Musculoskeletal complications, including scoliosis and chest wall deformities, may develop from thoracic compression or surgical repair. Long-term multidisciplinary follow-up is essential to monitor pulmonary, cardiac, gastrointestinal, neurodevelopmental, and musculoskeletal outcomes. Early identification of complications allows timely interventions, such as pulmonary hypertension management, nutritional support, and rehabilitation therapies, which are critical to optimizing overall functional outcomes and quality of life in CDH survivors. Long-term follow-up for infants with congenital diaphragmatic hernia is multidisciplinary, targeting the organ systems most affected by pulmonary hypoplasia and surgical repair. Pulmonary follow-up includes monitoring in specialized bronchopulmonary dysplasia clinics and screening for persistent pulmonary hypertension. Cardiology evaluation with serial echocardiography assesses right and left ventricular function and guides management of ongoing hemodynamic issues. Gastroenterology involvement focuses on growth monitoring, nutritional support, and management of gastroesophageal reflux. Neurodevelopmental follow-up incorporates early intervention programs, audiology assessments at 18 to 24 months, and surveillance for motor and cognitive delays. Surgical follow-up monitors for recurrence of the diaphragmatic defect or complications related to the initial repair. Coordinated care ensures timely detection and management of complications, supporting recovery and optimizing long-term functional outcomes. Congenital diaphragmatic hernia results from failure of the pleuroperitoneal folds to close during early gestation, allowing abdominal organs to herniate into the thoracic cavity. Clinically, infants present with a scaphoid abdomen, barrel-shaped chest, and absent breath sounds on the affected side. Immediate intubation is required, and bag mask ventilation should be avoided to prevent further lung compression. Ventilation strategies emphasize gentle support with low peak inspiratory pressures and permissive hypercapnia to protect the hypoplastic lungs. Surgical repair is performed after stabilization rather than emergently. Prognosis is primarily determined by the degree of pulmonary hypoplasia, quantified by prenatal markers such as the observed to expected lung-to-head ratio, and by the presence of liver herniation into the chest. Awareness of these principles guides initial stabilization, respiratory management, and perioperative planning, ensuring the best possible outcomes in this high-risk population.